Okay, you guys. This is Kaylee. I'm going to talk about an overview of HIV testing laws today. Oop. So really this title could have been Overview of CDC Recommendations and Testing Laws and Policy, but that's kind of long. So the objectives today are going to be to discuss the CDC recommendations for HIV testing of adults and adolescents in the U.S., summarize the current West Virginia HIV testing laws. I also, because I know we have some providers from Virginia, so I also reviewed those. I didn't put them in the PowerPoint, but we'll kind of compare and contrast them because overall they're pretty similar. And then just take notes as needed for Virginia specific. And then also compare the CDC recommendations to the current local state laws. So just to start, really in context of understanding HIV testing policy, it's kind of important to know, how and why it came to be to begin with. So really in context, the story of HIV testing policy really began back in the 1980s when evidence for addressing both the clinical and the public health challenges of HIV and AIDS was still really very unclear. So 1985, which is when I was born, first HIV antibody testing became available. And again, at that time, it wasn't really obviously not widely accepted. It was brand new. At the time, the really significance of what a positive test result really even means and the prognosis of the HIV process itself was still very unclear. So not widely utilized at that point. But really within the next year, over the next year, public health officials kind of became more on board with, hey, we probably should be testing more people for HIV. At that point, again, no policy, no laws were in place. But from the public health standpoint, they said, really this is a pretty significant contribution to really controlling the evolving epidemic. Now, they got a lot of backlash from AIDS advocacy groups, mainly because of the psychosocial aspect of, testing people in the advent of not really great treatment, discrimination, stigma, really, is it really going to be more harm than anything to be really testing more people for HIV? So there was a lot of controversy there. And that's really what initially led to the written informed consent policies and also to more specific pre and post-test HIV counseling. So fast forward a couple years, by 1989, laws were really more the legal norm for HIV-specific written consent. It did have to be a separate consent form than just the general consent to treatment. And then really by the early to mid-1990s, highly active antiretroviral therapy was becoming more widely available. So therefore meant more people could get good treatment in the US for HIV, improved ability to manage opportunistic infections. And really at this point was when targeted prevention programs were getting established. In 2005, Thomas Frieden, who was the New York City Health Commissioner at the time, he wrote up an editorial for World's AIDS Day. And his really goal was to seek more aggressive testing policies and make opt-out screening for HIV more routine. Actually, I have a quote for him because I didn't want to fudge it up, but he was pretty well ahead of his time. So he said, given the availability of drugs that can effectively treat HIV infection and progress on anti-discrimination initiatives, perhaps it might be wise that society is ready to adopt traditional disease control principles and proven interventions that can more adequately identify infected persons, interrupt transmission, and ensure treatment and case management to monitor and control efforts for HIV throughout the population. So basically was saying, don't make HIV testing such a big deal. That did not go over very well with HIV advocacy groups or AIDS advocacy groups at the time, again, for the same controversy that's been going on over the last 30 years, so really with the issues of discrimination. But New York City Health Department, not soon after he released this editorial, New York City Health Department actually released a similar statement as well. So interestingly though, it wasn't until 2014 that New York finally eliminated their written consent policy, which is interesting because they were one of the last 2 states to do this. Everyone else in the US had really been on board with eliminating written consent, besides New York and Nebraska, up until 2014. So in 2006, about a year after New York City Health Commissioner released that editorial, CDC kind of reviewed the data, recognized, hey, treatment's better, there's more prevention efforts now, we need to kind of get on board. They looked at the data and realized, 20% of people with HIV in the US don't know their status, so we might want to address that. So at that point in time, they really revised their testing recommendations, and the rationale behind their revisions were really to, again, increase the number of people who know their HIV status in the US, thereby reducing the number of new infections, to increase HIV screening of patients, including pregnant women in healthcare settings. And again, just remember, I think they specified pregnancies mainly just because of the mother to baby transmission risk, and also the fact that you're more readily able to transmit HIV during pregnancy and postpartum period. So they did specify pregnancy. Again, to further reduce perinatal transmission, to foster earlier detection of HIV infection, and also to identify and counsel persons who previously had unrecognized HIV so that they could be linked to care. So HIV testing recommendations as of 2006 changed to, instead of an opt-in approach to where you had to consent specifically in writing to testing, CDC recommended that HIV screening occur in all patients, in all healthcare settings, after the patient was notified that testing would be performed, unless the patient specifically declined. They did specify that they were in support of an elimination of specific written informed consent, and also that the general medical consent form could encompass HIV testing as well. They also recommended that persons at high risk for HIV infection should be screened at least annually, and also specified that really prevention counseling should not be required with HIV diagnostic testing or as part of HIV screening programs in the healthcare setting. And I believe they put that in there more so as they were trying to remove as many barriers as possible for people to get tested. So they recommended that actually not be a requirement or a recommendation. Not that you shouldn't counsel them, but just that it wasn't necessary at that point in time. So everyone between the ages of 13 and 64 should be tested for HIV at least once as part of routine health care. I don't know why they chose 64 as the cutoff, probably because, I don't know, people still have sex after 64, but that's the age range. At least annual testing if there are specific risk factors. So regardless of age, if there's specific risk factors, MSM. And in 2017, there were more specific HIV testing recommendations put out by the CDC in regards to gay, bisexual, and MSM, that in some cases, and this would really be up to the provider discretion, but that some MSM should really be screened more frequently, as in every 3 to 6 months. Anybody that's had anal or vaginal sex with an HIV positive partner, anyone that's had more than one partner since their last HIV test, anybody that's injected drugs and shared needles or works with others, anyone exchanging sex for drugs or money, and I want to expand that to exchanging sex for goods or services, because some people exchange sex for housing or transportation, not necessarily for drugs. Anybody that's been diagnosed or treated for an STD or STI, anybody you're diagnosed or treated for hepatitis, viral hepatitis, or TB. And then also, if your patient had sex with somebody who could answer yes to any of the questions above, or someone whose sexual history you don't know, they also recommend annual testing. As far as pregnancy, specific recommendations. All pregnant women in the US should be screened for HIV, and this is with every pregnancy, not just a one and done. Again, this is still opt-out screening. So the pregnancy recommendations really specify more explicitly to screen a woman after she's been notified of the universal recommendations for pregnancy HIV testing. Again, include this, make it more routine. This is just part of your routine prenatal panel, but again, give the option to decline. Offering HIV testing must be voluntary and free from coercion, and no woman should be tested without her knowledge. And then it also specifies too that pregnant women should really receive oral and written information that includes an explanation of what HIV is, how to reduce HIV transmission from mom to baby, and then what positive and negative test results mean, and give them more specifically opportunities to ask questions. Again, no additional process or written documentation is needed, even with pregnancy. And if a woman or pregnant woman declines HIV testing, this should really be documented in the medical record as well, including the reasons for declining testing, and then really address the reasons why the pregnant female is declining. Is it because she doesn't think she's at perceived risk? Is it because she is worried about being able to come back in for her results? Is it because she's involved in intimate partner violence and just doesn't feel comfortable finding out her status? So really trying to find out more specifically why they're opting out. CDC also recommends that a second test be performed during the 3rd trimester if meeting at least one criteria. Criteria listed below. So basically, if there's increased HIV/AIDS incidence among women of childbearing age. Virginia is actually included in this. At the time when this was revised, West Virginia was not included as having increased incidence, and still technically isn't. And that's really defined as more than 17 HIV cases per 100,000 persons a year. If they receive healthcare in facilities where prenatal screening identifies at least one HIV pregnant woman per 1,000 women screened, if they're at higher risk, or if their pregnant female has any signs or symptoms consistent with acute HIV infection. The CDC from 2006 put that a plasma RNA test should be performed in conjunction with an antibody test to diagnose acute infection. That's actually outdated. So 2014 was when they released their new testing algorithm. So really the standard of care test would be to perform combined antigen antibody testing in everybody, including pregnancy, because of that window period. So that's a little bit outdated on here. Any woman document is still pregnancy. Any woman document or with an undocumented HIV status at the time of labor should be screened unless she declines. Recommendations are for opt-out and at this point rapid testing. We have now a rapid combined antigen antibody test that really results in about 20 minutes. It's called the ALEER test. That's part of the testing algorithm as well. But that is one of the recommended during labor. If there's a reactive rapid result, recommendations are to go ahead and initiate ART therapy without waiting for confirmation. Still send confirmatory results, but go ahead and start antiretroviral prophylaxis. If a pregnant woman doesn't know her HIV status, or if that's unknown at the time of delivery, screen immediately postpartum. Again, all of this is still opt-out, so they still have to consent. And then if the mom's status is unknown postpartum, rapid test the newborn ASAP so that ART can be offered. And if the baby rapid test positive, really should be informing the mom that this indicates that she's infected as well. So now West Virginia state law. This is Code 16, Chapter 3. Senate Bill number 488 was the revision in March of 2011. So in 2011 was when West Virginia decided, hey, we're going to get on board with getting rid of written consent and do instead voluntary opt-out testing. Again, it specifies recommending this as part of routine screening. It could be oral or written. but also may be part of the general consent form. So whenever they sign their general consent for treatment, this can include HIV testing, but it has to specify in there, if it's written that way, that it includes consent for HIV-related testing. Testing, Senate bill also said offering targeted testing for high-risk behaviors. That was also congruent with the CDC, at least annual. And then offer screening if the test provides important information for care of the patient, if there's cause to believe it could be positive, if there's a significant occupational exposure, or again, if no record of an HIV test was recorded during pregnancy and the mom presents in labor. As far as minors and adolescents, there's nothing specifically saying that a minor can consent to HIV testing without parental or guardian notification, but it does say that they can consent to STD testing, and that includes HIV. Virginia is the same as far as minors. So it also specifies who cannot opt out. So if you're donating tissues or organs or blood or semen, you can't say, hey, I don't want this tested for HIV. If there's a documented bona fide medical emergency or for research purposes, they can't opt out to HIV testing as long as privacy is protected and their identity is protected. As far as prenatal testing in West Virginia, basically it basically is copied and pasted from what the CDC recommendations were, so I'm not going to go over it again. The only difference, this is West Virginia, the only difference was that we do say that we offer a second test in the 3rd trimester, preferably prior to 36 weeks, regardless of risk factors. So we went ahead and just encompassed all pregnant women should really be offered 3rd trimester screening as well. Virginia doesn't have anything specifically stating who to test in the 3rd trimester, but as part of their routine prenatal care law, they do say there that it should just be offered as well. So a little bit different verbiage, but essentially the same thing. Labor and delivery. I copied and pasted this from the WV law basically because 4.2.c.1 the rapid testing of newborns is recommended as soon as possible after birth, so antiretroviral prophylaxis can be offered to HIV-exposed infants when the woman's status of HIV is unknown postpartum. Some states have a mandated neonatal law for HIV testing to where if the mom's status is unknown, they don't have to consent to the baby being tested. You can go ahead and test the neonate anyway. West Virginia is one of those. So you don't have, so if the mom says, no, I don't want you to test my baby, you can still test the baby. Virginia, I couldn't find anything that specifically said whether or not the mom had to consent. So that's that. And then who gets mandated HIV testing? So who doesn't get a choice? You have to, if you're ordered to do it, you got to do it. So any person that is charged or convicted with prostitution, sexual abuse, assault, incest, or molestation, it's mandated HIV testing. This is confidential. Either the local county health department or regional jail can administer the test. Consent's not required, but it does include counseling. And then the Commissioner of Public Health, so in West Virginia, if somebody tests positive for HIV and they're at risk of infecting others intentionally, a cease and desist order can be administered. If they violate that, you can file with civil court to enforce it. And there's kind of a non-specific law saying that they can kind of be detained until they're not at risk anymore. In Virginia, if somebody intentionally infects another person with HIV, it's a felony. And they also have a statement saying that if in Virginia, you do not disclose your HIV status to sexual partners. Doesn't say anything about injection drug use, but to sexual partners, that's a class 1 misdemeanor. So that's a little bit different. As far as confidentiality, no person may disclose HIV test results permitting identification except to the subject, victims of crimes, or a legal guardian of a minor, a funeral director, or employee handling body fluids or tissue specimens on need to know. As far as partner notification, because I get asked this a lot, you know, if you have somebody that tests positive for HIV, what's your liability as far as making sure that partners know? The Bureau actually recommends that, you know, we would refer contact notification activities to the Bureau rather than attempt to do it ourselves. They have established programs and protocols in place. I don't know if you guys know about the disease intervention specialists. They're a pretty small group of people, but they really do all the partner notification and the tracking. And in West Virginia, there's actually an Internet Partner Services Protocol. So this group of individuals works with the state, but they actually can notify partners anonymously to get tested through like social media. So they can say, hey, you know, somebody you slept with might have HIV, you should probably get tested, which I think is pretty useful. If they can't track them down otherwise, that's one means to get a hold of people. Let me see if there's anything else I wanted to say about that. Oh, one thing about Virginia that I forgot to mention, if any person declines HIV testing or opts out, that needs to be documented in the medical record. In West Virginia, if someone declines HIV testing during pregnancy, it needs to be documented, but not necessarily in all scenarios. And then the other thing is that in Virginia, they have to be offered face-to-face notification of test results. So that's actually specified. If they have a positive HIV test, that has to be disclosed in a face-to-face discussion. They don't have to do face-to-face discussions with negative results, but positive results that warrants in-person interaction. West Virginia doesn't specify anything like that. I hope you wouldn't just call them and leave a message or voicemail over the phone, but you don't have to bring them in for the visit to discuss. You can notify them over the phone and then bring them in for counseling. And then, again, as of July 25th of 2019, everybody now has HIV testing laws that are consistent with the initial CDC recommendations that I went over in the beginning. There's a little variance among states, but overall, pretty consistent. Nobody now requires written consent, thankfully, so more people can get access to testing, which is yay. And then I listed a bunch of resources because I'm all about the resources. So the first one, if you click on the first hyperlink, it will go to, it'll give you a map of the US, and you can just click on each one, and it'll tell you, individually. It'll give you a link to each code for each state, and it even breaks it down as far as these are the laws for criminalization, perinatal testing, minor consent, reporting. The second link is just to the actual CDC recommendations from 2006. The third one is a link to WVU state law. The fourth is to Virginia law. And then the last three are more so resources. I think most of you guys have met Carolyn Kidd. She's been involved with Project ECHO with the HIV side intermittently and has presented, but she's part of the Mid-Atlantic AIDS Education and Training Center. So if you have any HIV questions, period, she's a go-to person for that. And then the last two, so case report forms. If you do have an HIV positive, I just listed those case report forms for adult and pediatric as well, just to make it a little bit easier to send that off to the state. And then the last one is just a list of, a link to a list of the reportable diseases because I think we should all just have that printed off and at hand just in case. So with that being said, does anybody have questions? It's just kind of an overview. That was awesome. Thank you. Thanks. Yeah.
Hello.
Hi.
I don't know whether we raised this question in the past. When somebody is HIV positive, what do you mention in the problem list? What diagnosis do you mention?
You can specify either HIV infection. You can even specify AIDS in their problem list. It's not as important now, but if they've had opportunistic infections in the past, it may be worthwhile to specify AIDS as well, and then list out what their opportunistic infections have been. But if you just list HIV in the problem list, that should suffice.
Okay. And do you need to make that note confidential for any reason? Like in our clinic, for the behavioral health notes, they make it confidential. So, because the problem list will be in every note we see the patient. Should we make it confidential?
So there's nothing that specifies that needs to be listed confidential. I think more so on the premise that whoever's accessing the chart should be on a need-to-know basis. So it doesn't have to be specifically hidden or not in a lit location that's readily accessible. It should just be that those who are viewing the chart should really not be entering that unless they need to know. Okay. And I know that gets a little bit because we have in our HIV clinic patients that they follow with their primary care locally, and their aunt or aunt's best friend or something is the secretary at the office, and so they're always worried about confidentiality breach. Again, that's something I would discuss directly with the patient, and if they request that it be not the first bullet point in their chart, then to respect that request. But legally, anybody accessing the chart really needs to have a reason to be in there. And if they're going around and telling people their status, that's a legal breach of HIPAA, really.
Thank you.
Thank you. Good question. I know that comes up a lot in real life.
Do you guys have any other questions about the didactic or about anything you needed to bring up today?
That's the whole thing. You don't know any of the laws.
How come Greg looks so clean cut today?
I know, it's
my
a
question.
haircut.
Dude, I was looking kind of semi-homeless. It was looking bad. I had to. It's funny. I have two sons, and my wife cuts our hair, and it's just three. It's the exact same. Like it's just boom, 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 just all three. It only comes one way, and this is.
You did a good job.
That she's awesome. She's good. She can't cook, but she's but she'll be the first to tell you. I actually had a question for John, if that's okay. I had a Lyme disease patient I wanted to bounce off you if you have just a second. So I had this guy, 31-year-old fella, came to see me for the first time, who had been to the emergency room 3 times. The first time just not feeling very well. It didn't really have anything, no real specific complaints, just kind of felt like maybe had the flu. They actually tested him for the flu. It was negative. Sent him home, had him take some Tylenol and Motrin. About a week or 2 later, he came back in feeling bad, kind of nauseous, vision problems, that sort of stuff. Just kind of general malaise. Nothing specific, but he was having fevers at that point, temperatures up to about 101. So they did some blood work for him at that time, which was pretty unremarkable. Didn't really see a whole lot. Did a CBC that was normal, a CMP that was normal. And I think it was about it, really. Sent him home, said, take some Tylenol, Motrin, drink plenty of fluids, be okay. He came back a third time, and he was having what sounded like meningeal symptoms. Like he was having, so he was having kind of vision changes, trouble leaning, he couldn't lean forward. And the guy, he looks like maybe he might be one of my Hep C patients, right? So he's got like a bunch of questionable tattoos, and his mom has been my patient for a long time. And she's a pretty rough lady. I've seen her for 7 years, and the apple fell from the tree and then kind of rolled back towards the trunk, I guess. Like he's pretty, kind of similar, but nice enough people. So when he went to the ER the third time, they actually did a CT scan of his brain, which was normal, and they did an LP. The LP was normal except for slightly elevated protein and kind of slightly decreased glucose, but nothing else exciting. Gram stain and culture were both negative. So they basically said, yeah, we don't know. I mean, everything looks good, but you need to get a family doctor and just kind of make sure that you do all right. So then he shows up to see me. So I go in to see him, and he's having fevers of 101, 102 at night, and particularly at night, especially. And he's lying down. So like when I walk into the room to see him the first time, he's lying down. He says, if I sit up, if I lean forward, I feel like I'm going to throw up. I mean, it's just, my head feels terrible. I just don't feel well. His temperature in the office was, I don't know, maybe 100. I mean, nothing terribly exciting, but a little bit elevated. And, he said, yeah, I just don't know what's going on. So if he's lying down, he was fine. If he tilted his head forward, it hurt. If he lifted his leg, it hurt a lot. So looked that way. So I told him, I said, you've been worked up really well, but the other thing that we would consider would be something like Lyme disease. So I started him on Doxy.
Cool.
When I saw him, and sent off testing. So all of this stuff came back negative except for the Lyme test, which was positive, but like violently positive. Like it was super positive. His blood, like his Western blot had had like 8 bands or something that were positive. It had a bunch, right? So, but that takes a while, at least for us, when we order that test, it takes a little bit for that to come back. So by the time the result came back, he had actually been on the Doxy for about a week. Mm-hmm. I had my nurse calls him, says, hey, it looks like you had Lyme disease. How are you feeling? And he's like better. So he feels much, much better. No more fevers, no more chills, that sort of thing. So I guess it's a long history, but my question is, like, would you consider this? Now, I didn't test or nor could I test his CSF. So I don't really know if it's Lyme meningitis, because when I reviewed your lecture that you gave on this, and I guess the treatment for Lyme meningitis is really a PICC line with ceftriaxone for several weeks. And I didn't do that, but he's now completely asymptomatic. Yeah. So I guess my question is, do I need to do anything else other than just tell him not to miss any of his pills and take the full 20? I gave him 28 days when I saw him. So I prescribed him 28 days and said, don't stop taking this until you hear something different from me. So now I just don't know what to do with him at this point. He's almost done his Doxy at this point. So at this point, he's like week 3. He's probably 21 days into the Doxy and feels good.
Yeah, and I think you're doing fine. Remember, if we weren't in the United States, we might use Doxy to treat Borrelia CNS infection. So in Europe, they actually use Doxy to do that. And certainly we've had good use of Doxy for as an alternative to penicillin drugs for like syphilitic meningitis if you had to. So the only thing in hindsight, if we could do it, would be to give them a higher dose of Doxy. Would have been like maybe the 200 milligrams twice a day, which is a hell of a dose. But if you can tolerate it, it's okay. What I'd do with him now is exactly what you did. I'm sure you've successfully treated him. The fact that he did not have a really significant white blood cell count, elevated pleocytosis in the CSF is comforting. But when you talk about evidence of spirochete involvement in the CNS, remember, like anything that you find abnormal counts. So even elevated protein could at least be like, huh, maybe he did have a little bit of and certainly his clinical syndrome sounds like meningismus. I mean, without a doubt, he had meningismus symptoms. So, dude, I think it's a fascinating case. This is kind of like one of those situations when you find out somebody had a bacteremia, but it's already better. And you're like, oh, crap, you know, look at this. This person somehow got their bacteremia treated with P-augmentin, and they're fine. You know, it shouldn't work by the books, but it does. And I think that your patient's exemplifying that nicely, that doxy probably treats meningitis fine. Or I should say treats Lyme with potential CNS involvement. Only thing I'd say, man, is if he develops any anything in terms of, I wouldn't set the stage too hard for him, like giving him expectations of bad stuff. But if you review his systems in a couple weeks, he develops any like radiculopathy, or starts really complaining of, you know, brain foggy type encephalitic stuff that really makes you worried, those would be the points where you would contemplate doing more therapeutics on him.
Yeah, and honestly, it'll be. I literally have met him once. I mean, I've only ever seen him in clinic just the one time, and I don't, you know, I don't know what his. I mean, I really don't. He's kind of a strange fella, and I know his mom, and so I don't know that I could tell. I guess I would just have to go based on subjective complaints. But yeah, it's. I don't know. It was an interesting case, but you don't feel like anything. Like, I mean, that's fine. That's plenty.
Remember, natural history stuff, if you didn't treat it, it wouldn't kill him. You know, you could just kind of let him get better. Probably not a good idea. Spirochetes in the brain, but yeah, I think that's fascinating, man. Great diagnosis, by the way. Congrats for thinking of it. I mean, eight bands Western blot positive. That's real.
It was a good day. I was happy when that came. I was as happy as he can be when anybody's test is positive, but it's nice because it gives him kind of he was really just kind of desperate for a clear answer as to why he felt so bad. I mean, he felt really, really bad. And this was, I think, as close as he'll come to a definitive answer as to why he felt so bad.
I love your duration. I'd keep him on the 28 days of doxy and just sort of see him a couple times and follow up, and see if you think he's doing.
Would you repeat testing to watch the band? I mean, did you just leave him alone?
If his bands are that positive, you probably won't even see anything like get worse, because you almost can't get worse. He's already got 8 out of 10 bands, and I would just let things calm down and get him treated and make sure stuff goes the right way. Again, radicular discomforts, if you started getting especially upper extremity or lower extremity radicular discomfort, or anything that made you start thinking of MS, you know, like weird cranial nerve, optic, motor, sensory problems, or serious brain fog, cognitive brain fog, you might consider MRI in him. And if you found something goofy in there, you'd say like, holy cow, wow, he's one of these genuine white matter disease Lyme cases, and then put a PICC line in him and treat him. But I think you probably did fine with the doxy. And again, if I literally have had somebody who refused the PICC line, and we went with the European approach and used 200 BID for Lyme meningitis as an option. And if the patient doesn't puke too much from that, they'll do fine, apparently, from outcomes. So cool stuff, Greg. Thanks for sharing, brother. Yeah.
Well, awesome, guys. Do you guys have anything else? If not, our next session is August 8th.
Cool.
And I will, of course, send out those reminders. Thank you, guys.
See you. Sorry I missed your whole thing.